Okay, can we get started? We have a quorum. We've got a quorum. 1, 2, 3, 4, 5, 6, 7, 8. How many we got? I can't see down there. 1, 2. What? We've got them online. Hello, everybody. Okay. Well, I'll call this meeting of the Health and Human Services Committee to order, and I do apologize for starting late. Please, if you are in the audience on a bill and you have handouts, you need to get them to us quicker than about 2 minutes when we're trying to get everything together and come over here with the handouts and things so we can put them in the packet. So finally we gave up and left before some of them are coming. So if you had something that you wanted in the packet and it doesn't get there, it'll maybe coming a little bit later when our secretary can get them. But if not, I'm sorry. Okay. Representative Newton, you wanted to go first. And can you do that on House Bill 629? Because I know that some of the committee members have questions. If you want to, wherever you're comfortable. Okay, this is House Bill 629. You've got the floor.
Thank you very much, Madam Chair and members of the committee. We're working off of LC 338715S.
Nope.
Ma'am? I am excited to present to you House Bill 629. This committee, under the chairlady's leadership, has expanded telemedicine in Georgia over many years because of the importance that the accessibility and the affordability and just the convenience that patients and consumers expect and frankly deserve. As a matter of fact, this whole committee, as well as the entire House just a few days ago, kind of validated that same effort that the chairlady has pushed for to expand some of the temporary telemedicine expansions that there were during the emergency orders this past spring. We saw how valuable those were. Certainly patients always have the opportunity for an in-person visit. What House Bill 629 attempts to do is to make sure that the spectrum that's available for telehealth, telehealth visits is one that doesn't exclude the practice of ophthalmology and optometry. Unfortunately, in some years past, there have been some bills that have been passed which actually specify not necessarily the professional standard of care, but at least the state legislature's opinion of the standard of care. And I think these were well-meaning and meant to preserve patient care. But the thing is, in the past several years, over 5 or 6 years since those were contemplated, telemedicine has grown greatly. Telemedicine, we now know almost every specialty has a spectrum of illness and complexity that they cover, whether it's emergency medicine and urgent care like I do, or pediatrics, or geriatrics. There's some things that's appropriate for in-person and highly intense one-on-one visits. And there's other things, usually at the other end of the spectrum of a specialty, that's appropriate, very appropriate for telemedicine. Now, once again, telemedicine probably will never replace everything you can get in an inpatient visit. For example, in my area, if I was to refill allergy medicines and we decided that we could meet the standard of care refilling allergy medicines, there's always a chance somebody could say, but well, my undiagnosed hypertension was picked up by an in-person visit. But we've acknowledged that telemedicine and telehealth is something that consumers want and that they deserve, and they understand the ability to have an in-person visit or to have a telehealth visit if on the spectrum of the specialty, it's in the safe range. What I would say through this is what's approved by the American Academy of Ophthalmology and others, that this spectrum of eye care, whether it's an optometrist eye doctor or an ophthalmologist eye doctor, has a spectrum of disease and a spectrum of conditions that need treatment. What this bill seeks to recognize is what's already approved medically by ophthalmologists, which is a comprehensive eye exam needs to be done every 5 to 10 years. That's the standard of care that's expected. What happens in this bill is you can have an initial in-person eye exam that's just like we do now, and you get fitted for contacts, and that can be a week or two long process to get properly fitted. Clearly needs to be in person. But the next year, if your contacts are working fine and your vision's fine, this bill allows you to go for just your refill of your contacts. And I can tell you the current standard of care that's operating by ophthalmologists is if you're between 18 and 55, you don't have hypertension or diabetes, and you're not having any problems with your vision, they can do a telemedicine eye exam. And that's what this bill would allow, which is basically the standard of care. These telehealth visits would be done by board certified Georgia licensed ophthalmologists. That's what this bill would allow, working under the standard of care, the medical standard of care, once again, not a legislative standard of care, but they would be working under a standard of care with these few times that a refill of a contact is really one of the refill of contacts that are working good, especially when are working well. They can do a telemedicine exam, and that just allows consumers a choice. If a consumer wants a comprehensive evaluation, they still have that option to go in for one. I've been told by people who wear contacts that sometimes they, because of the difficulty of scheduling an annual exam every year in person, they sometimes stretch out the use of their extended wear contacts because they can't get around to having the time for an appointment. Certainly that was true during this past year when a lot of in-person appointments were excluded. So what this would do, it would offer those consumers a choice. And so that's what House Bill 629 does. It offers a choice for consumers. It doesn't mandate that they do it. It still allows certainly an in-person visit, but it does allow for this low acuity and there is no zero acuity healthcare.
Okay.
I'm glad to answer any questions.
Okay, my first one is, the first one, when they're fitted for the contact lens, has to be in person?
Yes, ma'am.
Okay, I just want to make that clear. Okay, questions from the committee?
Representative Parsons here.
Oh, hold on, you have a question too? We'll go get you on the list, Representative Parsons. Representative Tanksley.
So your bill, is it that there are some requirements for some to go in for an annual reexamination and get a totally new prescription? Maybe not in your bill, but is that the practice of optometrists versus ophthalmologists, or?
Certainly the different boards, whether the medical board over ophthalmologist or the optometry board over optometrists, can set their own standards of care that they think that the members should abide by. Certainly there are specialty boards, ophthalmology or optometry or other specialties, that sometimes set guidelines that become the standard of care. Like I say, we've gone far in allowing a telehealth to be an option for patients and consumers if it extends their accessibility and the affordability. We like to be able to offer that. The standard now is due to the fact that it was put in state law, I believe in 2015, that refilling a contact lens that was working well required an in-person exam as well. And so therefore a telemedicine exam to do that is not allowed at this point. And that's what this bill would, I would say, correct, or at least maybe not correct as much as would advance us up into a time that wasn't like 2015, where we've had a lot more experience, the equipment's better, the interaction between both the providers learn more and the patients have learned more, and they like the convenience and the accessibility. So this just seeks to take it out of the legislative side of a mandated in-person exam annually and let you do it if you'd like. You can do that exam, but you can do it through telehealth.
Representative Newton, if I didn't know better,
Yes,
I would think that you're a lawyer besides being an ER physician.
No,
Can you
ma'am.
hold
No.
your answers to, we got lots of bills. And
I don't get paid by the
I'm giving you a
word.
hard
No.
time. So can
Thank
you be succinct, and members also be succinct?
Sure.
Thank you. I appreciate it. You did answer some other questions that I had in your presentation.
Okay, Representative Beverly.
Uh-oh.
Thank you, Madam Chair. This is going to be, it's going to be a little bit, it's going to take a little time. You guys may not know, but I'm a practicing optometrist in the state of Georgia. I've been practicing since 1994. when I graduated from optometry school. So for the last 25 years, just so you know. So I'm coming from a standpoint of a practicing person within this space. The first question I have is line 17, assessment. Can you tell me what that eye examination means? What assessment are you particularly doing when you say assessment? Because you struck out in person, but it says assessment. What assessment can a telemedicine exam do?
I would leave that. I mean, I do have some ophthalmology specialists that are glad to speak on probably many of the things you'll have more specific questions about. I'm not pretending like I'm an ophthalmologist or or an optometrist and do this every day, but I know you are.
Okay. Thank you. I'll go to the next question. One I want to raise is this, is that telemedicine, it's going to take a look at the lids, the lashes, the glands, the meibomian glands. It's going to take a look at the lens, the cornea, the aqueous, the vitreous. There's a lot of stuff that goes into an assessment that a telemedicine machine can't do. The next question is, will this assessment be able to take a look at the tear film on an eye? So as you know, we have tears on our eyes. The tears are made up of 3 different layers, right? There's an oily layer, there's a mucus layer, and there's a watery layer. Will a telemedicine exam be able to take a look at the layers of those tears?
This is not meant to replace a comprehensive in-person eye exam.
Okay.
It's not going to do, and you're right about those things. And frankly, all the eye exams I've done in trauma situations and other infectious disease situations in emergency medicine have always been in person. So this is not something that I, as an ER doctor, do or will do, but a board certified ophthalmologist may choose to do this. And I would offer the patients the option to see a board certified ophthalmologist or a board certified optometrist by telehealth. But it's not going to be, no, there's no way they're going to look at the retina. There's no way they're going to look at the vitreous. There's no way they're going to get the same thing that you and I get with a slit lamp.
Right.
Or when I take a piece of metal out of someone's cornea. Nothing's going to replace what that in-person exam, but it's similar when you do a refill of medications through telehealth as well. There's still some things that get left out. Nobody listens to the lungs on a telehealth visit. There's some things that are different, and we've just, both consumers and providers have learned how to do that in low acuity areas.
Yeah, very good. So I want to bring your attention to, and I would agree with you, line 19, ocular health. The reason I asked those questions about the tear film is because contact lenses, the contact lens actually rests on a tear film. It doesn't actually rest directly on the cornea. It rests on a layer of a tear film. And so if you can't assess that tear film, then you can run into problems with how that contact lens actually moves on the eye. Would you agree?
Certainly.
Okay. The next thing that the next thing I want to ask you is around the idea of visual status, which is line 20. And I want to bring your attention to visual status of an individual that does not consist solely of an objective refractive data. So an objective refractive data, for those who are not familiar, is when you go into an exam and a doctor shines a light in your eye and it just kind of gets an objective opinion. It doesn't go which is better, 1 or 2. So 1 or 2 is a subjective. Is this better or is this not better? Is there any instance where you can tell me where subjective data would change from year to year, not over 5 years? Is there anything within this bill that says, the subjective data has changed, which would require a doctor to take a look at you before that 5-year period, which you talked about earlier?
Yeah, there may very well be some answers that come to this and the people that will present on it later. I would ask a quick question, is because you're pointing out the differences between an in-person exam and a telehealth exam, and they are different. And I'll grant you that. What in optometry could you do on telehealth, if not refill prescription lenses that are working well?
Yeah, so I think
Diseases,
yeah, because we're talking
infection?
about I think that we're talking about, I'll go into that too, but I know that for the sake of time, we'll get into this debate, and I would love to continue this. And I want to get into that because I think there's some lines in the bill that I want to bring your attention to, and we'll get there if you let me just walk through just a little bit longer with this part of it.
It's up to the Madam Chair lady.
Just 1 or 2 more. Would that take care of it?
Okay. All right. So I don't know if I could do it in 1 or 2, but I'll get
Okay.
close. The next thing that I would ask, and so there are things, so you would agree that there are things subjectively that can happen within a year that a doctor needs to take a look at to make sure that a contact lens is fitting properly, just because something could happen. Someone could develop something called dry eye, where the tear film, they overwear their contact lens. To your point, people overwear their contact lenses all the time. And what happens is because the cornea is an avascular organ, which it doesn't require oxygen. If you put a piece of plastic
Sure.
on an eye that needs oxygen, that cornea is going to swell. And a lot of times you can come into a doctor's office, you're wearing your contact lens and the eye is swollen, which is a gateway for bacteria getting to the cornea surface and cause tremendous problems, both at the limbal area and within the structure of the fabric of the cornea. That happens every single day. So if we were to do a telemedicine exam, you wouldn't be able to pick up the subtleties of the layers of the cornea that may be potentially swollen because someone overwore the contact lens. And if you go beyond a year or two or weeks, you can have a real serious problem on your hands with people really creating a situation where there's a pathology that didn't exist when they got the exam, overwore their contact lens, the cornea gets swollen, and all of a sudden you have not only just an infection, but a change of prescription. Would you agree to that, doctor?
I'm sure the gentleman knows of what he speaks.
I appreciate that.
I am curious, are you saying that if an ophthalmologist thought this was a safe thing in 40 other states to do, that they're all committing malpractice if they refill a prescription? Or are you just saying it's just not best? Or are you saying you think it's actually wrong? Or is it just a difference of opinion between 40 states ophthalmologists and the 3 states, I think South Carolina and one other, and us, that don't allow this right now? I would probably contend that it is within the standard of care, and that they do have referral bases that they do if they find any of the concerns that you mentioned. I've been told that, but I would really much rather let somebody who's the expert on doing this continue the testimony.
Okay.
And I'm not the only one who seems like a lawyer in addition to what else they do.
Representative
good.
Beverly, if you don't mind, I think that I am sure on this list, and they didn't identify, do we have a doctor of ophthalmology or optometry that's going to testify in favor of this bill?
I
That could
think we
answer the
have,
questions
we
that-
just have the American Academy of Ophthalmology that has supported it. That's the extent of it right now. No, I don't have an ophthalmologist or an optometrist.
No, okay, I was just trying to see if there was somebody who could answer Representative Beverly's questions, is why I was asking.
There may be one of the online presenters that will
Most
be
of them
able to
are
do that.
online. Okay, do you know which ones can do it? I mean, or we can ask. So Representative Parsons.
Thank you. Thank you, Chairman. I'm sorry. Yeah, I think that with Dr. Representative Beverly there asking questions and some of the other testimony, my questions will be answered. I didn't realize there was going to be this much testimony and this much going into the bill. I had an optometrist call me a while ago, or actually not call me, but email me and have some questions. But I think those questions will be answered during the course of the testimony. But thank you, Chairman.
Okay, you're welcome. Representative Hawkins.
Thank you, Madam Chairman. Representative Newton,
Yes, sir.
I appreciate you bringing this bill. I know your passion for healthcare. Obviously, I'm a second signer on this bill. I have great faith in you. But as we've gone along the path on this bill, I'm sure some of us, or probably all of us, have gotten correspondence from back home. And there's a lot of confusion on this bill right now back home. And I know that sometimes we have legislation that goes through with confusion, but I don't know if this is a piece that needs to be done right now that couldn't wait until the confusion is resolved. And I apologize to you about saying this to you now, but we get sent here by folks that have trust in us. And I think some of my good friends, physicians and optometrists, maybe do not understand this bill. And I think maybe we need to think on this one a little bit longer.
Do you mind if the presenters that are prepared?
No,
go
I
ahead and
do
finish
not mind.
their-
No, I apologize about saying this at this point. This is all I'm going to say right now. But no, I think we should hear them. Thank you.
Thank you.
Representative Sharper.
Thank you, madam. Thank you, doctor. I'm right here. But I was on the same lines of Dr. Hawkins and others that, for one, I think that we should actually table this bill for one. And I was going to ask you if we could suspend it right now and get to some of these other bills possibly. But I think if you got some more people here, that's wanting to go ahead and do something, that's fine. But
I
That's
believe the
where I
people
am.
online had committed, the ones I've
online?
talked
Okay.
with, we're going to keep it very brief.
Okay,
1 minute, 2 minute kind of.
all right.
Okay.
Representative Petrie, do you want to wave or okay.
to say, I think I have some questions, that many of which hopefully will be answered in the testimony. I did want to mention that I hope that they will speak to the issue. I'm a little confused about the issue of whether or not this lowers the standard of care. There's some confusion there. But I did want to mention to Dr. Newton, I appreciate very much, obviously your opinion is very important to me, but I think you mentioned that ophthalmologists really expressed that 5 to 10 years is the standard of care for an in-person visit. Is that, I want to make sure I heard that correctly.
Well,
That's what I wrote down. Is that correct, Dr. Newton?
I mean, some of us have been more than 10 years since we've had a thorough eye exam. I apologize, but it's that is, yeah. And obviously, if you have illnesses like hypertension or diabetes, an in-person might be very inappropriate in the standard of care for skipping a year. That may clearly need to be every year. I believe that would be up to the ophthalmologist or optometrist to decide, and so just real careful, just the difference between standard of care as Georgia has written it in a statute and standard of care with medical professionals. We need to differentiate when we use that term. Which one are we talking about? Because like I say, 40 states have ophthalmologists, not all of them, I'm sure, but many of them in those 40 states that are doing this today very safely with good convenience and accessibility for the patients. So make sure on the standard of care when we say it's not just what's existing in 3 states.
Thank you, Representative Newton. And if I could, one quick follow-up, and am I correct that on line 23, it does state that this route could be reviewed by a physician or optometrist? So
Correct.
ophthalmologist and optometrist could utilize this new route, correct?
If they thought that for a subset of their patients, the contact lens refill was safe and appropriate to do and met their standard of care, and it didn't conflict with their board, yes.
Thank you.
Well, thank you. I certainly want to get a good bill out. I want to take the time that's needed, and I appreciate the committee's indulgence with our presenters as they've made some effort to be here, and I look forward to working on a good bill that doesn't have confusion. Thank you.
Representative Mitchell has waived his question right at the moment, or his statement. And so we're going to start with the people that have signed up. I think we have about 12. And so if you get long-winded, I probably will cut you off because there are other people that have bills here that we want to move forward. And we already know there's a lot of conversation about this one. Louis Massey or Chris Grimm, whoever's here.
Hi, Chris Grimm.
Pardon?
Hi.
Online. Sorry. Thank you. I forget. Identify who you're with.
Quite okay. I am Christopher Grimm, and I am testifying in support of this bill on behalf of Warby Parker. Warby Parker is a leading brand of eyewear. We started online. We now have dozens of stores all across the country, including 3 in Georgia. We offer comprehensive eye exams in our stores by optometrists or right next to our stores. That's an option available at many of our locations. We also offer a telemedicine service called Prescription Check. Prescription Check is an ability for patients to renew an existing eyeglass prescription. We're not currently doing contact lens prescriptions, just eyeglass prescriptions online by taking an online vision test. The data that is collected by that test is reviewed by a licensed ophthalmologist or optometrist in the state. We are active with Prescription Check in over 24 states. Would love to be able to offer this service in Georgia, and that is why we fully support this bill. It'll bring access to affordable, convenient vision care for Georgia residents, particularly those in rural parts of the state. Will pave the way for future innovation in eye care as well, all while ensuring that Georgia licensed optometrists and ophthalmologists are using the technology, are using their professional judgment to provide high quality care to their patients. Thank you, and happy to answer any questions.
Thank you for being succinct, and I take it that you are in favor. So the next person up, and then on, if you'll come forward, the first thing if you'll say if you're for it or against it, please. Ariel Kane.
Hi, that's me. I'm online. I'm Ariel Kane. I'm testifying in favor of the bill. I'm a health policy researcher and the director of health policy at the Progressive Policy Institute, a think tank here in DC. And my research is primarily focused on healthcare costs and access issues. And I think, as we've seen from COVID-19, telehealth can help improve both access while reducing costs. And under current law, Georgia treats ocular health differently than other types of healthcare when it comes to telehealth. Patients can see physicians remotely to renew drug prescriptions, but not eyeglasses or contact lens prescriptions. This bill would rectify that issue. During COVID-19, it's laid bare how some parts of the healthcare system maintain barriers to access solely for revenue purposes. To reduce costs and improve access, we need to make it easier for patients to access needed care, whether or not we are in a pandemic. I hope the committee will vote to approve HB 629 and make it easier for your constituents to get their eyeglasses and contact lenses prescriptions.
Thank you very much, Ms. Kane, but I would ask you, if you don't realize in doing your research, and I'm not voting on this bill as chairman, so I'm not putting opinion out, but it does seem to me that ordering a prescription, I mean, there is no way to look inside the body and see how that prescription, you have other outside indicators, but when it comes to the eye, you know, that is an organ that you can look at. So there is a bit of a difference.
I mean, I think it depends on the prescription. You know, people during the pandemic used telehealth in greater, numbers than they had before. Personally, I renewed my own prescriptions online without a physical health appointment. And yes, I get your point as to, you know, you have the availability to look at the eye, but if you also think of like a well woman's exam or something like that, that involves physical contact. But if you just make an appointment to renew your birth control, you're not getting the full well woman's exam. And, you know, we have decided as, the boards of medicine have decided that sometimes it's not necessary to have that exam every single time you just renew a prescription. And I think the same can be true for contact lenses. If you think about people who don't wear contact lenses or contacts, they are not getting an eye exam, you know, every year either. And of course, it would probably be good for those people to see an eye doctor every 5 years or so as well, but we don't require them to do so.
Right. Thank you very much. And thank you for your testimony.
Thank you for having me.
Nick Shaligo? I can't.
Yeah, Nick Shiligo. I'm also online. Yeah.
Okay.
Thank you, Madam Chair. Members of the committee, thank you for the opportunity to testify on this bill. My name is Nick Shiligo. I am in support and representing 1-800-CONTACTS and the 100,000 customers that we have in Georgia. A lot of the information that I would talk about has already been covered, so I'll keep it brief and be sure to answer any questions. But as mentioned before, these are not a replacement for a comprehensive exam, and we recognize that they are not a comprehensive exam. Our customers, when they log in, recognize that as well and understand that they're not going through a comprehensive exam and making that choice actively. These testing platforms have been in use for over 4 years. They simply allow for services and consumers to access services that can provide time savings, cost savings, and they have been allowed in 47 states, or currently allowed in 47 states, been operating for 4 years. You know, despite what you might hear around some of the negative impacts that can have from not having an annual exam, Ariel pointed out that, you know, if you don't wear contact lenses, you're not required to do that currently under the law. There's also been no scientific or medical studies demonstrating a significant uptick in health concerns just because individuals are using online vision tests in the 40 states that we're currently operating in, that we're allowed to. In addition to that, in that 4 years, we've run more than 1 million tests conducted nationwide with our consumers. At this time, we're unaware of a single adverse event, a single medical malpractice claim, a single consumer-driven complaint to a medical board, licensing regulatory body. We think that the data speaks for itself. It demonstrates that these services can be used safely and effectively for a patient population that matches the standard of care and the clinical guidance put out by the American Academy of Ophthalmology. That's 18 to 55, no pre-existing conditions, no previous eye surgeries, no prescription eye drops in the last year. Simply a tool to renew, a simple tool to renew contact lens and eyeglass prescriptions for individuals that have been probably using them for many years without any change.
Okay, thank you.
I'd be happy to
very
answer
much
any
for your
questions.
Testimony. Tony West.
Hi, I'm online as well, and I'm in support of this bill. Good afternoon. I'm the Deputy State Director for Americans for Prosperity here in Georgia. We're the state's largest grassroots organization focused on long-term solutions to our country's biggest problems. Really appreciate the opportunity to speak very briefly. We believe in removing barriers in healthcare that keep people from accessing the care they need when they need it at a price they can afford. And we believe this bill would remove a barrier for people seeking certain types of vision care. We also believe in promoting innovation and removing regulatory barriers that limit the legitimate use of new and emerging technologies. And we think this new technology, allowing you to get your vision tested online, promotes accessibility to vision care for anyone who'd like to use it, but could be particularly beneficial for lower income and rural populations. So for these two reasons, we ask for this committee's favorable consideration. Thank you.
You're welcome, Tony. We'll just have to get broadband out to the rural areas as we're trying to do for them to be able to access it if it should pass. Thank you very much for your testimony. And we are working on the broadband very hard to get it out across our state.
Thank you.
Servando Esparza.
Hi, Chair. I'm online as well.
Oh, okay. Thank you.
Yeah, my name is Servando Esparza, and I'm Executive Director of TechNet in the Southeast. TechNet is in support of House Bill 629. TechNet is a national bipartisan network of tech CEOs and senior executives that promote the growth of the innovation economy. In short, we're supportive of the bill because it would advance the use of technology in healthcare. Telehealth is fundamentally altering how patients experience care. New telecommunications technologies also allow healthcare professionals to provide patients with medical care and services in convenient, affordable, and accessible ways. What we've seen the last year throughout the pandemic is that a number of states, both providers and patients, have increased their use of teleservices, including telemedicine, telehealth, and telemonitoring. So we want to see the expansion of that. So for these reasons, TechNet supports HB 629. Thank you.
Thank you very much for your testimony. Margaret Meyer. Online too. Margaret Meyer. Okay. We'll just move on. Peter Horkin or Brent Rasmussen. Okay, moving on. Lee Buckner.
Correct. Thank you, Madam Chairman. Vice Chairman Newton and members of the committee, my name is Leah Vukmir. I'm speaking in favor of this bill. I am the Vice President of State Affairs for the National Taxpayers Union, the oldest taxpayer advocacy organization in the country. I am also a former state senator from the great state of Wisconsin. So I understand what it's like to be sitting in your seats, making important policy decisions like this for your constituents. We urge you as National Taxpayers Union to support this crucial telemedicine legislation authored by Dr. Newton. You know, one of the silver linings to the coronavirus pandemic, and there have not been many, has been innovation on behalf of healthcare workers and policymakers to provide Americans with access to healthcare at a time of pervasive lockdowns and, quite frankly, fear on the part of many. And this nationwide movement has played out across the nation, and the success of these policy changes has resulted in telemedicine evolving from a temporary necessity to a much needed permanent change. I won't go over the technology that's involved since others have already done that, but I would like to make note that under current law, as I understand it, Georgians can only use technology if they're physically seated in their doctor's office. And this, to me, severely restricts patient access, especially for those who live in rural areas. During a time when so many people are struggling financially because of the pandemic, HB 629 would allow patients to use this technology not only from the comfort of their homes, but also saving them well over $100 per renewal visit, bringing Georgia in line with the majority of states who currently offer access to this technology, as Dr. Newton mentioned. I think it's already been stressed that this technology and this testing doesn't replace the need for comprehensive eye exams. It is only to be utilized for renewal of existing prescriptions. I would not personally support this if it did not have that caveat to it. I am also a nurse, a pediatric nurse practitioner, so I really like the fact that this technology will point out the fact that individuals who have serious underlying health problems or even simple underlying health problems that would be contraindications to having their renewal done online would be notified that they need to seek care in person. I think that's really important, and I believe that's why the American Academy of Ophthalmology supports this technology. Finally, last but not least, this technology can provide savings to Georgia taxpayers. State government employees who participate in government-funded health insurance plans could significantly reduce overall costs at a time when states are grappling with budget constraints. Enacting measures like this that decrease state expenditures is very fiscally prudent. So expanding Georgia's telemedicine laws to allow for online technology for eye exams makes good sense and continues to move your state in the direction of progress and innovation. So as a nurse, as a former lawmaker, and as the representative of the National Taxpayers Union, I strongly support this bill and urge you to support it as well. Thank you so much for giving me this opportunity.
Oh, you're welcome, and thank you for your service in Wisconsin. I'm also a nurse, taught pediatric nursing.
Awesome.
And I have moved, and I will say this committee moved out, and it's over in the Senate, a comprehensive telemedicine bill already, and I'm very proud of my committee members for moving that. Thank you
Well,
very
thank you for doing that.
Let me see if Representative Hutchins, do you have a question for the presenter?
I guess it could be for the presenter because she was mentioning with the availability of broadband. And I know with telemed, you have to have very, very specific technology on the practitioner side to be able to see. I know for mental health, we have to have a certain level of technology where we can see the really fine details, like if someone is having a tremor or a tic or something like that. So in the rural areas where they don't have broadband, and we know that that's a huge swath of our rural areas, it seems like if that technology is not available, and it probably isn't, that you won't be able to have the technology you need to see the fine details that Leader Beverly was talking about earlier. It seems like if they don't have the right technology, if they can't get it in, if they don't have broadband, that this could backfire. That's what it seems like to somebody who this is not my field.
Okay, thank you. I think Representative Newton wants to answer that question for you briefly.
And once again, this is just what it's been explained to me. The multiple capabilities in telemedicine, including store and forward, were incorporated into this, similar to what we did in the earlier telehealth bill, and it helps allow that that lack of a broadband connection, but a kiosk or some other way to gather the data and then send it all in a packet for an ophthalmologist to review as a telemedicine visit. That's contemplated in the bill to meet that very criteria.
Okay, thank you. Does that answer it for you, Representative? Okay, Alexis Almond or Kyle Zeppeli?
Yes, Alexis Almond here. I'm online. Thank
Okay.
you. Today I'm representing the American Telemedicine Association. So thank you so much for the opportunity to speak with you all today. On behalf of the over 400 organizations we represent, I'm speaking in support of House Bill 629. The ATA applauds the legislature's efforts to enable the use of telemedicine technologies in the practice of eye care in Georgia. Across the United States, patients and consumers are searching for more convenient and affordable ways to access the healthcare they need. Our organization maintains that policymakers should not mandate the technological modalities by which practitioners deliver care to their patients, so long as the practitioners are providing services within the scope of practice and meet the standard of care. Again, we thank you for your efforts to expand telemedicine in Georgia, and please let us know how we can be helpful in your efforts to adopt a sensible telehealth policy in Georgia. Thank you so much.
And thank you for being so succinct. Courtney Jocelyn?
Yes, I'm also here online.
Okay.
So I will keep it brief. Many of the testifiers before me have mentioned many of the things that I want to, but I will say we are in support of this bill at the R Street Institute, which is a nonprofit, nonpartisan public policy research organization. And we engage in policy research that supports free markets and limited but effective government. And during the pandemic, we have closely followed several telehealth reforms across the country. And I will say of all the reforms that we have followed, which includes telehealth expansion in many ways, including to different services, to different providers, and including different telehealth methods. Allowing contact lens prescription renewals online is the least controversial that we have followed, as it has the most evidence to support its success and the fact that it works for millions of Americans already. Many of the telehealth expansions that states are currently grappling with are in things that are relatively new. And so this is a reform that has been relatively without controversy on the issue of safety and efficacy, and also including increasing access to a convenient and affordable method of renewing contact lens prescriptions online.
Okay, thank you very much. Audrey Berlines?
Thank you,
Short and
Madam.
sweet.
Thank you, Madam Chair, members of the committee. I'm Aubrey Valines, General Counsel for the Georgia Optometric Association. I want to thank Chairman Newton for meeting with our team of 4, and we're here in opposition to the bill. We do support telemedicine. We support the chair's bill 307, which was in real time. The language, this bill is not in real time. We think there is a place for our telemedicine, but we don't think everything is conducive to telemedicine. I want to comment a few things I heard there, that there's been no adverse reactions or adverse situations. I think a recall of the machines is pretty adverse. This was back in 2019. This is not just an optometrist situation. You have letters up there that we submitted kind of late with at least 8 ophthalmologists that have signed against this legislation. What this legislation does, the committee substitute, is after the first initial eye examination, you wouldn't have to have it again. That's the first thing it does. And I want everyone to understand that there's not a barrier that exists. You know, getting an eye examination is not a barrier. It's a good healthcare practice. And we think that practice should go on. Right now, every optometrist, after he does an eye exam, has to, by law, mandate, give a copy of the prescription, which then can go to 1-800 in Utah or wherever you want to send it to, and get your prescription filled online. That barrier just does not exist unless you want to call an eye exam a barrier. In our opinion, with the utmost respect, this is a change in the standard of care. And yes, regarding contacts and eyeglasses right now, it's a year. It's an annual thing. If you'll look at the bill, also I want to point out something that hasn't been mentioned yet. That's on page 3, line 57 through 60 and 61. We have what is called a diagnostic lens and diagnostic period, where you try on the lens first and see if it works. And during that time, then you go through the final fitting. This, I believe, abolishes that. I'm not sure if it abolishes it after the first initial or if it kicks in. It's just not clear there. I just don't know. I had that happen to me recently when I had a daily lens and I put it on. I tried to get it off. And so I called the doctor and said, this just isn't going to work, and did that online. We've been doing telemedicine throughout COVID. We support telemedicine. Some things are just not conducive to telemedicine. A couple of other things, and I'll sit down. You got to be able to pull up the lens and look under the lens and see what debris is there, and see if blood vessels are all swollen, see if there's edema there. There are things that machine just can't do. Cataracts, glaucoma, diabetes retinopathy, eye tumors, iridis edema, hypertensive retinopathy, macular degeneration, genetic retinal disease, tumors. I can go on, but I think I've got other doctors that are going to go. It can't judge the peripheral vision. The last time this legislation came up, the way they measured it in that high technology, they said, take your shoe and do so many lengths of your shoe and distance yourself from the computer, and that way we'll figure it out and start the test. Shoes vary in size. I know that. Anyway, I don't think the technology has reached that level regarding eye exams this way. There's certain things and many things that you can do online and do by telemedicine. We don't think this is a good idea. We think it's a lessening of the standard of care with the utmost respect to everyone. Thank you, Madam Chair. I'll answer any questions anyone may have.
Go away, Audrey.
Let me get my shoe back on though.
And you know I'm teasing you. There are no questions.
Okay, thank you. Thank you, Madam Chair.
Dr. Jeannie. Oh, you got a question? Okay, your light didn't go up quick enough.
I'm sorry. Thank you, sir. Thank you for being here. You spoke to some, I had made some questions here. I wanted to make sure that as we have been moving, rightly so, increasingly towards telehealth, as Chair Lady just spoke to earlier, and for all the obvious reasons. So you're telling me that optometrists right now today are embracing telehealth and you're using it broadly. Is that, I'm not putting words in your mouth, but you just, is
Yes,
that
sir.
fair to say that y'all are using it for a multitude of other procedures or
Yes, sir.
looking at people with eye infections? Or tell me how expressly how optometrists today are using telehealth.
I'll give you three
Otherwise.
examples of my own. We were designated first as essential healthcare providers by the governor during COVID. And so we've been using, but I can give you three, and the doctor who's going to follow me give you more. My contact that I just told you I was having problems with, I couldn't get it off, and it was a daily wear. I called right on the phone, telehealth, with my doctor, and he said, they're more difficult, Aubrey, to get off. Let me give you some lubrication, get some lubrication and be able to pull it off. The other thing, I had a sty pop up. Got on the phone, telehealth again with my optometrist. This is just a month ago. And he said, just warm compresses, Aubrey. So I never had one of these. He said, just warm compresses. And then I've also in the past, even before COVID, been on the phone with it when my eyes got really, really bloodshot when I was down in Brunswick about something. It wasn't from doing something I shouldn't be doing. It just got that way. And I called and he ended up getting a prescription called in. Those are three.
All right, let me just say this then. Thank you. So optometrist, to make sure I've got it, it's not that you're opposed to telehealth in a multitude of other areas, but as it relates to an annual eye exam, it appears, and we're going to hear more testimony, it appears there's some confusion or disagreement with the ophthalmologist and the optometrist about what the standard of care is for a physical in-person eye exam. Is that fair?
I think it is fair to say that, yes, we think you should have an annual exam. And I do not believe the Medical Association of Georgia or the Georgia Ophthalmology Society have taken a position on this bill.
Thank you. Thank you, sir.
Okay, thank you, Aubrey. Dr. Jeannie Perrine? Okay, and if you will be very succinct, please.
Thank you. Thank you for having me. And I am against the changes that are being made to the health HB 629. And I do feel like it lowers the standard of care for the practice of optometry and ophthalmology in regards to prescribing and caring for our patients. I think our patients deserve better than just telehealth. I've used telehealth, and I know many practitioners have used telehealth, but there are just some things that only the doctor knows. And as far as I'm concerned, who's making that decision? The patients, it seems like to me now, are starting to make their decisions of when they want to go instead of what's been studied for years and years and years and what has been standard. Why do you want to change the standards now when who's going to lift up that eyelid? Who knows? Who's going to tell? You think a computer is going to tell a patient, oh, lift up your eyelid so I can look under there and see if there's any disease? I mean, that's where everything lives when it comes to contact lenses. So I really think This would be wrong for the citizens of Georgia. This would be very wrong. We have optometrists in most every community. I don't know of anyone that really can't get care in Georgia. That's what I mean. So I think it's very wrong to consider any of this. Also, as far as the doctor's offices, they are equipped to handle emergencies, but you know what? Our computers? No, they're not equipped. So as far as ocular health care, this is a microscopic exam. This is not an objective exam just like on your hands. These are microscopic structures that need to be examined by a doctor. Thank you.
Representative Newton, I think you wanted to be recognized. You're on.
Thank you, Madam Chair. I appreciate your testimony. No, I didn't have a question. Thank you. I just was
I thought you were going to make a suggestion or a motion.
I am going to make a motion. Yes,
Okay.
ma'am. I do recognize that there is an essence of time with this. This is certainly something, as some members have said, we want to make sure we get right if we're going to join the other 47 states where this is considered safe. But I don't want there to be confusion, and I don't want there to be, I think it should have ample time. I'd like to move to table the bill if the committee so agrees.
Okay, I think that as chairman, I can make the decision just to say that we're going to, lay it on the table for further study without having to take a vote.
Thank you, ma'am.
I will make that decision that we will postpone any further decision on that bill for right now.
I do thank all the presenters, though, as well, on both sides. Thank you.
Okay, Representative Newton, you have another bill. Do you still have a meeting to go to? Do I need to do this succinctly for you, or can you do it very succinctly?
I'll try to do it succinctly.
All right,
as
this is
best I
House
can.
Bill 450.
Thank you, Madam Chair. House Bill 450 is kind of a cleanup bill. It resolves a problem. The state several years ago has allowed different conditions to be treated with medical marijuana. We have a registry for that is kept under the Department of Public Health. Additionally, the Department of Public Health has other information on our PDMP, our opioid and controlled substance list. One of those, the PDMP for opiates and all, is very carefully protected, but it does allow the information to be used for research when appropriate if it's de-identified, consistent with the HIPAA privacy conditions. What this bill does, House Bill 450, just uses that exact same language to apply to the marijuana registry. Several years ago, we added intractable pain as one of the issues that could be treated. Well, one of the things that the researchers were hoping to be able to find out is over here in this PDMP, did the rates of opioid use, did the prescribing go down as well? Because there's a way they can do that without releasing the identity. There's some hope that Alzheimer's and end-stage dementia and some other areas might be treated by low THC marijuana or cannabis oil with a prescription or with a doctor's care. It would be helpful to be able to look and see if the sedatives use went down. And so this bill, by mirroring the same language for de-identified data that's privacy protected to apply to the registry for low THC cannabis oil, to match that's in the opioid and controlled substance registry, this would just match that up, and it would allow the department and others, researchers, to use de-identified data and do the research and find out, for once, medically, is this really working? Is it just adding a new addiction, or is it actually lowering opiate use or other sedative or controlled substances? So that's what the bill does, Madam.
So basically, in a nutshell, it just like the PDM, where researchers can access that information to do studies, it would allow the same thing to go with the marijuana registry.
Yes, ma'am.
Thank you very much. Okay, questions from the committee? Okay. No questions from the committee. Is there anybody in the audience that wants to address this issue? Okay, all right. Go ahead, Representative, you've got the floor.
I make a motion that we do pass HB 450 LC 338684S.
Okay. All right, we have a motion and a second. Is there any further discussion? Okay, everyone in favor, say aye.
Aye.
Anyone opposed, no. Okay, the ayes have it. You can go to your meeting, Dr.
Thank
Newman.
you. Thank you.
Okay, Representative LaRicca. And be succinct.
Members of the committee, I rise to present LC 338697S. Many of you have heard this. This bill simply allows paramedics on EMS personnel to administer shots to individuals that have the congenital adrenal hyperplasia. They already have the medications with them. The seal is not broken. The expiration date's intact, then you can give them a shot if they go into crisis. I'd appreciate your favorable consideration.
Are there questions for the representative? And we discussed this at length at the last meeting, and we corrected any change that was needed. It had to do with what kind of training paramedics get and which ones could be put on there because they had the training to give IM injections. And that those are the changes that were made. Who's 7? Representative Sharper.
Thank you, Madam Chair. Thank you for, getting with Betsy and the others to.
Yeah, I was going to say thank you, Representative Sharper, but I had so much pressure to be succinct. I didn't get around to my thank yous. But thank you, all of you, for the help on this bill.
All right. Well, I appreciate you, and it looks a whole lot better.
Absolutely.
I think it's great.
Okay, anyone else? Oh, Representative Hogan?
I'd like to make a motion.
Okay, we have a motion to pass. Do I hear a second? Any further discussion from anybody? All right, everybody in favor of the passage of the bill, say aye. Anyone opposed? No? We got it. The ayes have it.
Thank you, Madam Chair,
You're
and members
welcome.
of the committee. Y'all really have been a lot of help on this bill for me. Thank you.
Thank you very much. Okay, we have Representative Stevens. Okay, and Kathy? I'm not sure. Where's Representative Stevens?
He got called to Savannah. He had to go all the way to Savannah to do a meeting, and he's coming right back.
Can I have that in writing, please? You sure he's not just letting you because we like you better or something? No.
Well, I appreciate it. And so on behalf of him, this is a very succinct bill. My name is Kathy Kazava. I'm the president of the Georgia Food Industry Association. We have supermarkets across the state, also representing the pharmacies in our stores. Also here on behalf of the Georgia Retail Association, and the Georgia Pharmacy Association is in the room as well. So we are all together on this bill. This is a very simple bill. Basically, we're in favor of House Bill 316. I'm here on behalf of Chairman Stevens. And what this bill would do is change the statute around how many technicians a pharmacist may supervise at one time. So currently it's a 3-to-1 ratio with 1 certified technician, and this bill would change it to 4-to-1 with 2 certified technicians. And this bill would help both our large and small pharmacies across the states who have been administering all the so many of the COVID-19 vaccinations. I talked to Kroger just a few minutes before I walked in. They've administered over 55,000 in this state alone and do about 15 to 18,000 a week. So this would help us in a big way, and we appreciate your support on this bill.
You're having a little problem with that y'all are giving so many that the doctors can't get it for their offices. And we have patients that, only want their doctors to give them the vaccine. It's sort of an equitable problem that we're having because especially patients with comorbidities are saying, they really don't want it at the pharmacy. Nothing against pharmacies,
Right.
but just that they would like to be able to get it in their doctor's offices and the doctors cannot get the vaccine.
Well, we are appreciative of everybody that's doing it. And I know Dr. Toomey and the governor are getting as many as we can possibly can. And we certainly support all of that.
Like that. So,
Thank you.
okay, I do have a question. Greg, you want to come up from the pharmacy board? It seems like that we are weakening oversight on this bill. And when I go into my pharmacy, it's Walgreens because I live in the metro area, so I don't have an independent. I mean, they are worked to death and it doesn't look like there's much oversight at all. How does this bill really, not weaken that and make sure that there's not a lot of mistakes made?
Yeah, so thank you, Madam Chair. On behalf of Georgia Pharmacy Association, Greg Reibold. So the tech expansion is definitely something that the Pharmacy Association has taken a close look at. And I would note that this does not change sort of the responsibility of a pharmacist to directly supervise technicians. And so, pharmacists will still have to be in the prescription area or in the pharmacy area. This doesn't change the supervision requirements, but what it does do is it adds an additional technician, provided that they have sort of that certification. And the hope is that this is going to, give pharmacists some help, some much needed help behind the counter.
And when they have that certification, what are the technicians allowed to do?
So technicians are not, the law restricts them from doing anything that has sort of like professional judgment, frankly. And so a lot of what they're doing is going to be doing labeling and counting pills and putting them in bottles, et cetera. But they're not they're not counseling the patient. The law and the board rules don't allow that. So they're not having that counseling patient interaction, and they're not engaging in practices that require, quote, professional judgment as the law specifies.
Okay, but they are putting certain pills in certain bottles and need to make sure they put them in the right one.
That's correct. Yes. And all of that is ultimately checked by a pharmacist before it is dispensed.
I mean, I'm not trying to be difficult. It's just that I see how busy they are. And with the added thing of giving the vaccines, it just, I'm just concerned about oversight. Okay, thank you for that.
Thank you, Madam Chair.
Okay, other questions for either Greg or Kathy? Okay, Representative Petrie.
Thank you, Madam Chair. I have a question. So explain, I know you just explained what a technician can't do. What exactly does it mean for a technician, those of us here to understand, to be certified? What does that require, and what precisely types of things are they doing?
So ultimately a certification is kind of a higher level, right? There's not a huge barrier to entry for pharmacy technicians, and a certification is a higher level that technicians can pursue who are, sort of taking that career seriously or have a stronger interest career-wise. Ultimately, a certification is going to come via a test. And so they have to do a test. There are several programs where technicians can go to school as well. As I understand it, I'm not an expert on this, but as I understand it, those programs can range from 12 to 24 months for those pharmacy technician programs. And then ultimately, it's not just going through the course. They have to ultimately take a test as well.
And this bill would require, explain again real clearly, so how many of these 4 that are now supervised with the visit by the pharmacist, how many of them have to be certified with this higher level?
Yeah, yes, sir. So, under current Georgia law, the ratio is 3-to-1. Pharmacy can supervise 3 technicians, provided that one of those technicians is certified. This would take it to 4-to-1, provided that 2 of those technicians are certified.
Okay. Other questions from members of the committee? Okay, is there, see, we have people that want to speak on the bill. Oh, Representative Mathiak, sorry.
Is it not true that our technical colleges have a very good technical pharmacy program? Because I think the one in my town does.
Yes, yeah, that is my understanding, that's a program that several of the colleges do offer for technicians.
Thank you, Madam Chair.
Okay, thank you for that question. Any other questions from members of the committee? Okay, there's no one listed to speak. Anybody that wants to speak on the bill? Okay, seeing none, okay, I got a motion that do pass, and second, do I have a second? Second, okay, any further discussion? Okay, everyone in favor of the passage of House Bill 316, say aye.
Aye.
Anyone opposed, no. All right, the ayes have it and the bill passes. Thank you for the
Thank you. On
information.
behalf of Chairman Stevens, I appreciate it.
Okay. All right, let's see.
Madam Chair,
Yes,
this is Representative Sheila Jones. I just want you to know that I have been voting. I'm online, been here since 2 o'clock.
okay, thank you very much. Michael has been watching that. Thank you.
Okay, thank you.
Okay, Representative Hogan. You can, okay, this is House Bill 591. Yes.
Okay, thank you, Madam Chair and members of the committee. I present today House Bill 591 LC 338644. This bill came out of the Georgia Behavioral Health Reform and Innovation Commission, and it does one thing. It allows licensed marriage and family therapists to do 1013s and 2013s. And that's basically the bill.
Okay, Representative, one of the things that came up that was brought up by one of the members, not our members, but one of the marriage and family things, that there is a subsection of like associates or something, and they were concerned that they would also have this ability.
It's my understanding they will not have that ability. They need to be licensed
Okay.
to do the marriage and family counseling, and they need to have a background in mental health and practicing mental health services.
Michael, can you get up and introduce yourself and tell us who you are and explain to us the difference in the levels?
My name is Michael Chafin, former president of the Georgia Association for Marriage Family Therapy, former president of the American Association for Marriage and Family Therapy, and thank you, Madam Chair. You have to be fully licensed in order to be able to, this bill will authorize fully licensed people to sign 1013s.
Or
What kind of
2013s.
Pardon?
Or 2013s.
Correct.
Right.
What is a 2013?
That's for alcohol and drug.
Okay,
Substance abuse and alcohol.
substance abuse. What, I mean, how are these associates or whatever? What was somebody bringing that up? I want to understand.
Well, our programs are accredited by the National Association. Graduates from our programs get to take the exam, and they get a temporary license called an associate license. That helps them get jobs.
Okay, but they would not, they have to be fully licensed, not with a temporary license under this bill.
That is correct.
Okay, that's what I was trying to find out. Okay. Identify yourself.
Elizabeth Apley, I represent the Association of Marriage and Family Therapy.
Take your mask off,
Oh, I
Elizabeth.
apologize. I look so much better that way.
Uh-oh.
OCGA.
With your
40
designer mask, that's right, okay.
OCGA 4310A13 makes clear that there are different licenses, that there is a licensure as a marriage and family therapist, and there's licensure as an associate marriage and family therapist, and they are legally required to use that title, associate marriage and family therapist, and they're not included in this bill.
Thank you. I just wanted to make that clear and what the difference was, since, I mean, a lot of people don't give temporary license, so this is one area where you do give a, what they call a temporary license, and I take it that would be until they have further education or further hours of experience or.
Minimum of 2 years of supervision, sometimes as many as 4 and 5 years.
Okay, thank you for that information so we know the difference. Representative Hutchinson.
I was just going to echo what everyone has been saying. And I looked at the bill, and that was one thing I really was looking for. They have, in social work, we have an LMSW, which is the associate's license, and the LCSW, which is after you've done 3 years of supervision and taken a really intensive exam. For marriage and family therapy, there's an associate's degree, and then there's the license LMFT. And the same thing with a licensed professional counselor. The associate's license is LA, what is it?
PC.
LAPC, right. So there are associate license for all three of those practicing mental health diagnoses, and the associate's license, according to the bill, the associate would not be able to 1013 or 2013, and that's the same with all the other disciplines.
Okay, thank you very much for that information. Okay, any other questions for the committee? Oh, hey, who wound you
It's me
up-
again.
Who wound you up today with your questions? It's okay.
I drank too much coffee this
Now,
morning.
Representative
I just want
Petrie.
to make a comment, really. As I discuss this measure, I just want to mention that I have great respect for the sponsor, who is a psychologist and somebody I have great respect for and his knowledge of this area. And so I have learned over the years how important it is to have individuals treated in this fashion with a 1013 and a 2013 And we need to make sure that we have individuals like that in the community so that people can get the help they need. So I'm supportive of the measure, knowing the background that Representative Chairman Hogan has. Thank you.
All right, we have some, I don't see any more questions for the committee. We have Steve Butler online.
Yes, ma'am. Hi, this is Steve Butler representing NAMI, Georgia, and we do support the bill and appreciate Representative Hogan bringing it forward.
Thank you very much, Steve. And we have Steve Livingston.
Yes, I'm Dr. Steve Livingston. I'm in Savannah, and thank you for the opportunity. I'm a licensed marriage and family therapist in Georgia. Disclosure-wise, I also currently serve on the composite board, the Georgia Composite Board for marriage and family therapists, social workers, and professional counselors. I was appointed in 2011 by Governor Deal, served as chair from 2014 to 2018, and still serve on that board. And want to be clear that I'm here as an LMFT, and I no way represent the board in this matter or any positions that the boards take. This is strictly my own position. Although I can respond to, the discussion earlier about the LAMFTs and the LMFTs. This strictly will apply to LMFTs, full licensed people. And I'm here to speak primarily to the qualifications and educational requirements for LMFTs. Currently in Georgia on our board, all three of the disciplines have statutory authority under 4310A to evaluate, diagnose mental illness, and so we're already seeing patients in our offices for mental health issues, and there's a shortfall here with social work and professional counseling having this the ability to 1013 and 2013, and marriage and family therapists still not having that privilege, even though we have patients in our office that really need this service at sometimes. And so what we're really, where this shortfall is in our ability to be able to treat our patients in a time when they really need it the most. And we are treating marriage and family therapists the same as professional counselors and social workers treat folks with mental illness and substance abuse. So the privileging is really necessary. I have taught at the graduate level in social work programs at the university level. I've taught in counseling programs, and I've also taught in marriage and family programs. All three disciplines similar, and basically all three have the same training. The board here requires a psychopathology course in training and diagnosis and treatment of mental disorders for licensure for all three categories, so that the education that all three get is similar, but only marriage and family doesn't have this privilege right now.
Okay, thank you very much for your testimony.
Thank you.
I don't think anybody, I think the one thing I think about a year or two ago, there was something like 12,000, things issued, and only about 4,000, I think, is what they thought where people really needed them. My concern is that everybody that has a right to write a 1013 or a 1020, be very careful in writing them, because those stick with a person and can keep them out of the service, can influence their lives in various ways. So it has nothing to do with marriage and family people. It's just that now a whole lot of people are able to write them, and it is maybe everybody take extra caution about the ones they write. Thank you very much. Representative Hutchinson.
I just wanted to answer that question for you, Chair Cooper. It is, we might have the ability to 1013 and 2013, but it is so very difficult to get placement. I don't know any one of my practicing friends that does this on a regular basis. So in my experience, it's just not happening. It's just, you can't find beds. And if you 1013 somebody, you have to stay there with them until you find a bed. So usually we send them to emergency rooms. That's not best practice, but it's realistic in Georgia.
Right. We do have a lack of beds and a lack of facilities to treat people, and it is a problem in the emergency room, as you're right, is not the place for them to end up.
Madam Chair, I did meet with Commissioner Fitzgerald and her staff, and they do endorse this bill.
Okay, all right. So Doug, I see you're here. Do you have anything to say?
No, Madam Chair, just that we are supportive of it and appreciate the chairman bringing this.
Great. And I think we have one last person, Michelle Smith.
Thank you, Madam Chair. I am sharing also as an MFT. I work, I'm Dr. Michelle Smith. I work at Wellstar. I got my PhD at the University of Georgia in marriage and family therapy and have worked in this field for over 20 years. And my focus, what I want to share today is just the importance of access for people who are safety personnel and military veterans. We've had an increase in suicide among military veterans continuing over time. Georgia's numbers are slightly less than the rest of the Southeast, but still 10% higher than the general population for military veterans. And our safety personnel, particularly firefighters, have a very high rate of suicide and higher than police officers. And both of those groups have a higher death rate from suicide than they do from being killed in the line of duty. And the way that we most frequently see these people is when they come in for other issues, whether it's dealing with a child, like a parent-child interaction, or some stress and anxiety issues. And it's important that when we do the assessment, safety assessment with them, that we have the ability to then get them to a place where they will be protected and evaluated and treated.
Okay, I think that's everybody that wanted to speak on the issue. Okay, what is the pleasure of the committee? I'm sure, Don, you want to make a motion. Okay, we got a motion and a second. Do pass. Is there any further questions or discussion from the committee? Okay, if not, hearing that, everybody in favor of the passage of the bill, say aye.
Aye.
Any opposed, no. The ayes have it. Okay, Representative Schofield, if you will move very quickly on this, it shouldn't have been on today because it's a House resolution, and we can do that after crossover, but if you will.
All right, thank you, Madam Chair, and thank you, members of the committee. I bring to your attention House Resolution 188. It's LC 338646. The resolution supports the creation of the State of Georgia Work Group to increase chronic disease, healthcare information and screenings in communities of color. As we know, the COVID-19 pandemic exposed a lot of racial disparities in communities of color. These disparities have always existed, but the pandemic heightened the awareness. We need to start taking the real steps to address these underlying issues. This resolution addresses the fact that communities of colors have significantly higher rates of diabetes, heart disease, lupus, respiratory disease, kidney disease, and others. Addressing these diseases early and in an organized manner will help reduce the high economic, clinical, and social burden on patients and on our healthcare system and state. The work group actually will focus on developing projects to increase chronic disease information in screenings, especially incorporating the use of telemedicine and telehealth as a means to improve both. The work group is really in lines 45 to 58 is a cross diverse section of people that need to be at the table, and will report out within 9 months of passing of the resolution. Medicine as a whole is in full support of this resolution. Any questions?
Are there any questions from the committee? Leader Beverly.
No questions at the appropriate time. Motion do pass.
Okay, don't have any questions. Okay, we have a do pass and a second. I didn't ask, is there anybody in the audience that wants to speak on the bill? No? Okay, so we have a do pass and a second. Everyone in favor, say aye.
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 Opposed? No? Okay, the ayes have it. Okay, that leaves it to me. Thank you for sticking with me so that we have a quorum. I'm going to do House Bill 377. Okay, if you remember, I think it was last year, although I am losing track of the time in the years, whether it was last year or the year before that. This committee saw fit to pass out a bill that said we would not shackle pregnant women in their second and third trimester of pregnancy in our prison systems or by our sheriffs. That was a good step, but this bill takes it a little bit further. We do have a special prison for pregnant women in the state. It's certainly better than having pregnant women spread out in prisons all over the state because they can concentrate on making sure that they get the care they needed. However, it's an older prison and the conditions are not optimal. So what this bill does, if somebody is going to be in our penal system, the state's penal system, it gives the judge the opportunity and the person and the woman the opportunity to delay their incarceration until after the pregnancy has ended for a period of 6 weeks. Now, during that time, and one of the major factors of deciding that is the safety of the public that the judge would make the decision on, and the safety, of the woman. You could have somebody that had been, for some reason, in sex trafficking and had committed something to be in prison, and it wouldn't be safe for that woman to be out and in her community, and she might choose to begin her prison system and getting out of the way. You could have somebody that just says, I just want to get this over with. Or, the judge could decide that they were a danger to the public, or for some other reason that he didn't feel like that this would be the right thing to do. During that time, the woman would have an obligation to make sure that they got prenatal care, whatever, the judge saying using community services, public health, whatever was available in their community, so that they were not just out and not having prenatal care and not being checked on a regular basis. After that would happen, then if they decided and the judge said to delay it, then after they delivered in a 6-week period, giving them time to bond with the baby for a shorter period of time, they would start their prison system. That basically is the bill. Representative Lott.
Thank you, Chairman Cooper. I would just like to say, I appreciate you bringing this legislation, and I'm sure others have had the same scenario in their community, but I certainly have been reached out to. And I think it's important because our correctional facilities are not necessarily set up to deal with pregnancy. I think it's something that they just don't have a full appreciation for and I hate to say that, it's not to be insulting. I'm sure that they're trying to do better and better as time goes on, but understanding what a pregnant woman is going to need, both for comfort level and all of the problems that they have along the way. And we don't want to be on any mattress under 12 inches thick. And so, there are just a million things when you are a pregnant woman. And I think that this is a great opportunity, as long as the safety of the community is considered in the judgment made by the judge, that this is a reasonable piece of legislation. And I can't thank you enough for bringing it. And it certainly helps folks in my community. So thank you.
Thank you. Thank you, Representative Lott. I was trying to, in a nice way, when I talked about our prison that's set up, to, hint at the fact that even though it was better that women were not in just the general penal system, it wasn't the best. And thank you for helping explain that. Representative Hawkins.
Yeah, thank you, Madam Chairman. Thank you for bringing this bill. This is a bill that we should have thought of a long time ago, I think. But let me ask you a question, and you made me think when you brought this bill, what happens now when a woman has a baby and she's incarcerated? Is she separated from that baby?
Yes.
During the entire time? She doesn't get to see that child till she's
Now, I don't
Released from
know about,
prison?
I don't know about visitation. Do you know about visitation, Representative? To a family member
Oh,
or
okay.
up for, I mean, if it's one that's going up for adoption into our, foster care system.
Okay.
But I don't know. But as far as being with the
Okay.
mother,
Yeah.
no, it's my understanding. Okay, we have somebody that can testify to that. And is Pam here? Okay. Sure.
Answer those specific
You
questions
can,
as
well,
well.
stand for the question and then,
I will stand for the question. Hi, I'm Amy Ard. I'm the executive director of a nonprofit called Motherhood Beyond Bars. And for 6 years, we did all of pregnancy education and support inside of Georgia prisons, so 2 facilities. But we also support every single infant born to a woman in Georgia prisons. We work together with their caregivers. Women who deliver within the Georgia Department of Corrections have 2 hours with their baby after birth before they're separated. Moms go to the inmate floor and babies go to the NICU. They are supposed to be able to visit with one another, but staffing concerns, there is not enough staff to get correctional officers, excuse me, up to the NICU. So often all that woman has is 2 hours with her child after birth before she goes back to prison, and a caregiver is called to come to the hospital to pick that infant up. We know that visitation has been shut down for a year. So no woman that has delivered a child in Georgia prisons or jails has physically seen their baby for a year.
and now, if we're not under COVID, what happens? They take the baby and they give it to a family member. If there's a family to give it to, or they go into our system.
Almost every single mother who is in the prison system identifies a family member or a friend. The reason we started our program is because we began to hear troubling stories of these infants being passed around. There is no state agency that follows these children once they've been born and are in the care of a caregiver. So Motherhood Beyond Bars now provides all of the support services for caregiver families. And one of the reasons we did this is because we knew that later down the road, many of these children did end up in state custody because the caregivers simply got overwhelmed and weren't being provided with resources.
And if it does go to a family member or they have your support and the mother's in prison, are they allowed to bring the baby for visitation at certain time, just to?
That is the least likely form of contact between children and their incarcerated parents is visitation. Most of these families, we now know for the first time ever where these families live and where these children live. And there are a large number of them in the central south portion of our state. As many of you know, Lee Arundel is in the northern part of the state. So that could be a 4-hour drive for someone with a newborn or a young child to stand out in line and wait, hopefully, to get in for visitation. For most of these families, that's a journey that's just too hard to take. So they're counting on video visits, phone visits, and we know that even those can be quite a burden to the family in terms of expense.
Thank you.
Yeah. Would you like me to give my wholehearted support for
Yes, I
HB
would. Thank you.
377?
Okay, we've
Yeah.
got questions. Representative Mitchell wants to ask you a question.
Yes, let me to get my arms around this issue. And once again, I do too wish to thank the author, Madam Chairman, for bringing this forward. Representative Hawkins, it's strikingly similar to a proposal that Representative Schofield brought previously.
Exactly.
But I will ask you, help me get my arms around this problem. How many pregnant women are in this class that this legislation seeks to address?
One of the problems, this legislation really focuses on women on the jail level. And in our earlier bill, HB 345, we asked that data collection from the jail level be included in that legislation. And the very last vote on the Senate floor for that bill, it was struck. We don't know how many pregnant women are in jail and no one is collecting that data. I have some staff that have spent a good portion of the last month calling every jail in the state. And I can tell you that right now in one county jail, there are more pregnant women in Clayton County Jail than there are in the state at this moment, 9, when we were in touch with them. That's one county jail.
Well, and if I may, Madam Chair, with judicial bias, and as you mentioned, certain counties looking at those accused of crimes a little differently than others, we leave this total discretion up to the judge to decide who gets to go home and who gets to
That
be
wouldn't
impreg-
be, that would not be the bill that I wrote, but it is the bill as it stands right now.
Incredible.
Well, Representative Mitchell, you know how the judges are about judicial discretion. And they have-
It is more my hope that the bill gets through even with judicial discretion than not getting this bill done at all.
And I think it's like we've talked about before. Pamela Wynn's going to testify after a while, and Pam lost a baby in prison. She is a registered nurse and got in a little bit of trouble and went to prison, and she lost one from being shackled, and she's pushing this. She is the impetus behind this. And what we've said, and as she's pushed, if it doesn't work, I know who will be knocking on the door in my office and sitting there saying, this is not working. And there she is in the back. And she will be pushing for us to make a change in the law. And I do hear, we have had cases where there were problems over the past year, and I hear from Pam, and she finds somebody to help the mothers out. And I'm sure she's probably come to you. And I guess what we call it is one step at a time.
Yeah. Madam Chair, that's why the advocate, I think, is so right. Why demographic and actual number collection is so very important, because you can readily see where the discrepancies are and the biases are, something that can be then readily remedied almost immediately.
Representative Mitchell, that was in the bill to the last minute, and the sheriffs insisted that if the bill was going to pass and if to get it out, it had to come out. Okay, Representative Bennett.
Good afternoon. Thank you, Madam Chair, and thank you to the author of this wonderful bill. Madam Chair, I was there when we passed the no shackle bill for second and third trimester, and I want to thank the supporters of this bill. My question goes to, not my question, but my point also goes to the data collection for the infants. We know that there is a syndrome called failure to thrive. And so I would too encourage that we collect data on the mothers, but also that we at some point begin to follow the children, the babies that are born. So I wholeheartedly support this humanity bill, and I'm so thankful for the authors for bringing it. Thank you, Madam Chair.
You need to thank Pam Wynn, who's the pusher and the mover behind here.
Thank you, Pam. I can't see her, but thank you.
And I will tell you that Representative Schofield helped me. She ran back and forth and getting changes on this bill when I probably wouldn't have had that time, and we talked out the input on it, and also she certainly had a lot of input on the bill, and I really appreciate the help. Representative Hogan. You wait. Pardon? Yeah, okay. Representative Schofield.
Thank you, Madam Chair. So I just wanted to say to Amy, I'm very definitely 100% in favor of data collection. Just in the last 90 days, how many times have I been called and having to intervene on these problems with pregnant women? And so we need to. So thank you for being here, and thank you for all the work that you've done on this, you and Pam.
Right. Quite a family. I think that in how they approach our community service. I want to thank you too. I worked with your husband, if I'm not mistaken, on the retaliatory eviction law last year. So it's a family committed to community service. And I thank you along with Representative Schofield and all of us for that. Representative Lott.
Thank you, Madam Chair. I just wanted to respond a little bit to the comments that Representative Mitchell made regarding the judges. I don't find any problems with that portion of this legislation. I think that we have elected judges in our community. We have an expectation of them to do one thing primarily, and that is to use good judgment. And the accountability for their actions is held within their community through elections and whatever manner they need to hold them accountable. And I think that's still a very comfortable piece of this legislation.
Okay. Representative Mitchell.
No, I think that's a wonderful sentiment. The fact of the matter is, I think that we all know that there are some people who we wonder why they were elected for to serve one day, let alone terms. The reality is, if everyone who was elected, particularly those who have judicial discretion to take someone's freedom, if that were the case, as you say, they would have no problem with data collection and demographic information as well.
Thank you for your testimony.
Yeah, well, I didn't even get to give it.
Well, would you, okay, we're running out of time.
I know. I did want to, a little bit about what Motherhood Beyond Bars is prepared to do if this bill passes. I mentioned that for 6 years, we provided childbirth education and support inside the prisons. COVID has shut down our programs. We have moved all of those programs and are working in collaboration with DCS, Department of Community Supervision. For any justice-involved woman who's on probation or parole, we're providing childbirth education support. We provide diapers for at least a year, up to 2 for all of the clients in our program. So as women move out of the jails, this legislation would move them out of the jails into community. We have the infrastructure to take those women, put them into our programs, connect them with community-based organizations, make sure that they're getting health care. So I want you to know that there is some infrastructure already available in the community to make sure that these women get the care that they need. And that we also know that jails are often the very ones that the sheriffs are going to the courts asking that these women be bonded out because they are simply unprepared to deal with the challenges of taking care of pregnant women in their custody. So thank you so much for your attention to this bill, and I urge your favorable consideration.
And we have one more person. Pamela, come on up here. The mover and shaker, Miss Wynn.
Madam
Ms.
Chair, thank you so much. You know, I'm excited right now. I'm trying to contain myself. You work with me, Rep. Schofield. A lot of you worked with me on 345, which was dear to me because, as you stated, I am an RN. That was my background. Maternal health was my specialty. And I was served a 78-month sentence for white collar crime where I was pregnant, I was shackled, which caused me to fall and miscarry my baby. The facility that I was at in Lovejoy, Georgia, could not take care of me. I received no medical care. I ended up losing my baby. I was also placed in solitary confinement. So this is my lived experience. This is not just something that I think is a good idea. This is something I know. And although with your help, you all's help, we did pass 345 and it's a great bill. However, we still have problems. We are still having women that are shackled, that are still being placed in solitary confinement within the county jails. As Madam Chair said, we do have Helms that is a state facility that houses these women. However, the biggest part of our problem is with the county jail and the municipal jails. And if Helms is an older jail and is not adequate to take care of them, these smaller jails definitely cannot. We have, as my colleague Amy Art said, we have been basically doing this in the backgrounds. We had a woman in Augusta, is that called Webster Detention Center? That was released for 12 weeks because they recognized that they could not care for her properly. And they allowed her to be released for 12 weeks to have her baby and then return to serve her sentence. So we're not asking for anyone to give these women anything. They will be held accountable for their crime and for the mistakes that they made. But what we're concerned about is the health of that baby who is innocent, who is unborn and who did not do anything, as well as the health of that woman who still has a life once she is held accountable for the mistake that she made and had to come back home. And right now, the way that it is, as Ms. Art told you, if they don't have somewhere for these babies to go within 24 hours, they lose their babies, they lose their parental rights. So imagine having to pay for a mistake and then on top of that, not know where your baby is, if it's being cared for properly, not being able to see your baby, and then still having to come home and try and get your life back and still fight for your parental rights to get back your child, your baby that you had. So this is very near and dear to my heart. I've been working very closely with Rep. Schofield and Madam Chair, and I implore you, I beg you, please Make it happen.
I don't think you have to cry. I sort of get the feeling on this committee that we're probably with you 100% of the way. And I tell you what, I'll just go ahead and put the icing on the cake, so to speak. And it's certainly not why I moved this bill, but we will save a lot of state money.
Yes.
To rehab or start that prison would cost millions and millions and millions of dollars. And to have women stay out of that and having to do that is a huge saving for the state. And like I say, it's not my motivation about it, but it's just a fact. And so the difference in the care, since the care is required, we're not letting these women off. They're going to
course
have
not.
to get the care that they need. We're so much better off, and the woman and the baby will be so much better off. So thank you very much. I'll give
Thank
you a big
you.
bear hug when we're through.
Yes,
I've
I
had
appreciate
my
you
shots
all.
and stuff. I can do that. I'll put my mask on.
Okay.
Representative Hutchinson, you're the last, I think. Wait a minute. Who's Representative Hutchinson? There you are.
Oh, I thought you were about to say something. I just wanted to commend the authors and everyone who worked on this bill. This bill takes a lot of empathy and sympathy and work. And that's not qualities that the general public usually assigns to the Capitol. So I think this is a wonderful, wonderful bill. And I think it's also a first step to move towards more humanity for our prison population. So I just wanted to thank everyone who worked on it.
Thank you. Okay. Representative Mitchell, you have one last statement?
Yes, I would. I feel like
You go.
crying as well after
Good.
hearing Mrs. Wynn's remarks, and I'm almost reluctantly going to support this because I believe that the chair is going to work on second and third and fourth steps for this legislation as well.
She will, I promise.
Yeah,
I'm gonna stay on her.
the notion that somehow judicial discretion could be somewhat regulated by elections, I think is farcical in that the majority of opinion of the community elects folk, but the true democracy protects the safety and health of those minorities as well. And I'd hate to see when we do our own independent study that depending on your class or neighborhood or whatever, you get the judicial discretion, and those who are wealthy and well-connected get the discretion. And that's my only problem with this.
And I do understand your concern, and it's very valid and it's very real. And like I said, we're gonna stay, just like with 345, we've been staying on top of it, keeping up with where it's not being respected and addressed properly. We're gonna do the same thing with this. I agree with you. Originally, the way that we wrote it, we did not have that, but it was required to give these women something. So we agreed in order for them to have something, but we will stay on top of it. And if it does seem to be a problem, we would definitely be back up in here.
I make a motion to pass.
Okay, I got a motion and a second. That's what you wanted. Thank you very much.
Aye.
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 Thank you. I appreciate you all so much.
House Bill 567. This bill passed out of this committee, and I think it passed out of the House last year and got over in the Senate during COVID, and it stopped. Newborn screenings are so important because often the newborn screenings, and I don't know, they're up to about 24, 25 tests now. How many? Okay, John, come on. How many tests is it now?
We are right now at 36.
36. Oh, okay. I'm way behind.
No, 33. I'm doing math while I'm trying to talk.
Okay, 33.
33.
Okay.
bad.
And what they're testing for are very unusual, very rare in most part, diseases that can only be detected by these tests and need to be detected very shortly after birth, or they begin to cause irreparable damage. Every couple of years, somebody comes and says, Representative, will you move a bill for a certain, this is new, it hasn't, it hadn't been found before, and this causes, this or that. And by the time we get through with it, it seems like it takes us a couple of years or more to get it through. This legislation sets up a committee that would review these. They would meet twice a year. They would go ahead and see what it was going to cost the state. So that would be done for us. And then we could move in a much quicker fashion to add to this group of tests so that we can prevent any or another infant from being damaged and having a life of disability because we didn't get these tests done soon enough and their problems were not diagnosed. Does that, John Walraven, who's lobbying for this group because it's close to his heart, would that get it in a nutshell?
That's it, 100%.
All right. Are there questions from the committee? Thank you. Anybody else in the audience that would like to speak to it? Okay, we have a motion and a second for a do pass. Any other discussion, any questions from the committee members? Okay, everybody in favor of the passage of the bill, say aye.
Aye.
Anybody opposed, no. The ayes have it. Thank you to everybody stayed to let us have a quorum and for your support. Thank you very much.